Good evening, everyone, and thank you for joining us tonight for Inspira's Spirit of Women program and our webinar, The Road to Breast Health. Your journey starts here. I'm Michelle Marshall. I'm the AVP for Oncology Services, and I will be your moderator this evening. Before we get started, I wanted to cover just a few housekeeping items. First of all, just a note, this presentation is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health care provider with any questions you may have regarding a medical condition. We're using a new platform tonight with lots of fun bells and whistles. We refer to it as the Cadillac of virtual platforms, so feel free to click around and explore. All of the windows on your screen are resizable and movable, so you can move them around to get the most out of your experience. Make sure that you check out the resource window that has links to materials that pertain to tonight's event. At the bottom of your screen, there are multiple engagement tools that you can use. As usual, we encourage you to ask questions throughout the event using the Q&A button. Your questions will only be visible to us as panelists, so we hope that you'll feel comfortable to ask whatever's on your mind. And just a reminder, we cannot see or hear you. Throughout the presentation, you'll also see poll questions pop up on your screen. All of your responses will be anonymous, and we encourage you to participate. That's what makes this fun. Finally, you'll receive an email after this event with a recording of the webinar. So with those details out of the way, let's get started. The purpose of today's program is to provide an overview of breast health, including a discussion of prevention and early detection, as well as what Inspira can offer to you should you be diagnosed with breast cancer. You'll see the topics that we'll cover here on the slide. You can think of these as pit stops along your journey. As the webinar title states, your journey, whether you're at the point of getting your first mammogram or whether you're a breast cancer survivor, your journey with Inspira as your partner starts here. It starts today. And with that, I'm very pleased to introduce our speaker for this evening, Dr. Nandini Kulkarni. She's going to serve as our GPS tonight, our guide along this road to breast cancer. Good evening, Dr. Kulkarni.
Good evening, Michelle. Thank you for having me here.
We are thrilled to have you. Let me tell you guys a little bit more about Dr. Kulkarni. She is a surgical oncologist, a member of Inspira Medical Group, and the medical director of Inspira's Surgical Oncology Program. Dr. Kulkarni completed her full medical school training, including residency and fellowship, at premier academic institutions in India. Upon moving to the U.S., she then completed a second residency and fellowship with a surgical residency at Abington Memorial Hospital, followed by a fellowship at Fox Chase Cancer Center, where she focused on complex general surgical oncology. She's double board certified in general surgery as well as complex general surgical oncology. Dr. Kulkarni specializes in breast cancer, as well as management of melanoma and other skin cancers, liver and pancreatic resections, gastric and colorectal resections, and soft tissue sarcoma. With over 12 years of surgical training and more than 2,000 surgeries performed, she combines her passion for learning and research with genuine regard for improving the lives and experience of patients suffering from cancer. Before I turn things over to Dr. Kulkarni tonight, let's start with a quick poll question of the audience. This is a yes or no. Have you or a close friend or family member had breast cancer? Give you just a couple moments here to respond. All right, final answers. Let's see what you said. Oh, it looks like we didn't get any responses in. Well, I'm going to assume that the majority of you, we may have a technical difficulty with that, but I'm going to assume that the majority of folks on the line probably are familiar with someone who has experienced this. And that's kind of what we expect to see. We know that breast cancer has a very high incidence level. So Dr. Kulkarni, can you tell us a little bit more about some of the facts and figures related to breast cancer?
Absolutely, Michelle. So the breast cancer statistic that is very alarming and surprising in some situations is that 1 in 8 women will be diagnosed with breast cancer in their lifetime. So when you are amongst a group of friends, it's more than likely that one of you will be diagnosed with breast cancer in your lifetime. In fact, a new breast cancer is diagnosed every 2 minutes. It does tend to be the most common cancer in women, other than skin cancer hemisphere of the world, accounting for almost 30% of newly diagnosed cancers. And the heartening news is that there are more than 3.8 million breast cancer survivors.
Yeah, I like to focus on that last number. I think that's really powerful. There's almost 4 million survivors. So while the incidence numbers are high, the survival numbers are high as well. And so that's encouraging. So one of the first pit stops along the road to breast health is really understanding our risk factors, especially what's controllable, what do we have a little bit of influence over versus what can we not control. So let's shift our focus there and start our conversation tonight.
Right. So, two of the things that we are never going to be able to control is the fact, your gender. So the fact that you're a woman and that we are going to grow older, two things that I'm not going to be able to cure tonight does tend to influence your risk for breast cancer. Other uncontrollable factors include, the fact that you may have dense breasts. This just talks about the amount of fibrous and glandular tissue in your breast. And that's just a normal component. It's just like saying someone has dark hair or brown eyes. Some women have dense breasts. And that may increase your risk for breast cancer. A strong family history of breast cancer or ovarian cancer or even other different types of cancers like melanoma or colorectal cancer may influence your personal risk. Your own history of breast disease, have you had several biopsies in your lifetime? Has any of those biopsies demonstrated any atypical cells? That itself could affect your breast cancer risk. And then there's estrogen exposure. So hormone exposure, is a natural thing for a woman. We have the estrogen and progesterone as the hormones circulating within our blood. But there are certain factors that influence how much estrogen exposure you have during your lifetime. That includes the number of pregnancies, the age when you get pregnant, what age you started menstruating, at what age did you achieve menopause, and then, of course, any additional hormone use during your lifetime, whether it was in the form of birth control pills or hormone replacement therapy. Now, while some of these may be uncontrollable factors, some of the controllable factors include one's weight or BMI, whether or not you're drinking alcohol on a regular basis, how much are you exercising on a daily basis, do you smoke or not? So these are risk factors that are actually within our control. So the recommendation is, trying to eat a healthy diet, moderate amount of exercise every day, avoiding smoking altogether, not just for breast cancer, but for, your overall health and several other diseases that could be prevented. And alcohol consumption, if that can be limited to social occasions or just infrequent alcohol consumption, is something that is controllable.
In almost all of our education sessions that we do, we talk about the importance of a healthy lifestyle. And so that certainly rings true with the message that you delivered here for us tonight. So let's talk a little bit more about prevention and early detection. With breast cancer, we are fortunate that there are some concrete steps that we can take to catch breast cancer early. And so these screening and prevention measures really fall into three main categories. We have breast self-exams, we have imaging, and we have risk assessment or family history. So Dr. Kulkarni, can you walk us through each one of these in a little bit more detail?
Sure. So when it comes to breast self-exams, the recommendation is doing monthly self-breast exams. It's for a lot of women, that come to that come to the office, tend to say, Dr. K, I have no idea how to do my breast exam. I hate to do my breast exam because I don't know what I'm feeling for. Or my breasts are lumpy and I just don't know which one is new. I kind of get paranoid. I feel anxious when I feel a lump. And all of the above is true. It does provoke anxiety when you're doing your self-breast exam. what I try to tell everyone and what I would like to emphasize tonight is, that one of the ways in which you can take charge of your own health. Understanding your own body doesn't mean that you have to diagnose something wrong. It's just understanding what your normal features, your normal body looks like, feels like. So when you're doing a breast exam, this diagram, very appropriately reflects how and what is the most ideal method of doing it. We generally say stand in the shower when you're doing your breast exam, and then when you're laying back. And an ideal way is to kind of go in a circular motion, starting from the center and moving outwards. And then, of course, not forgetting that, you should feel under your armpits as well. That's where you may feel any enlarged lymph nodes, sometimes an occasional tumor that's way out in the axilla, in the armpit, may be felt. So understanding the look and feel of your breast so that when there is a change, or if there is a change, you're able to catch it. That's the premise of doing a monthly self-breast exam. Of course, if you notice any changes or if you're concerned about something that, you didn't see last month, the ideal thing would be to contact your physician, whether that's your primary care physician or your OB-GYN, just bring it to their attention so that they can take the appropriate next step. I put a big exclamation mark on this because not all breast cancers start as a lump. A lot of us, by the time the breast cancer is found as a lump, is already in an advanced phase of the cancer. It is so much more useful if you're getting your screening, and we're going to come to that in a minute. And we see abnormalities on imaging that are way before the cancer might be detectable by your own exam or even a physician examining you. So I do want to, kind of emphasize that while self-breast examination is very important, screening in other forms is just as important because not all breast cancers may present as a lump.
I think that's really important information. Too often, I think women do think, oh, I don't feel anything. I'm fine. I don't need to go for my mammogram. And you very clearly dispelled that myth for us tonight. So thank you for that. Now, we're going to try one more poll question, and hopefully this one works for us before we move on to imaging. So let's see if you're able to answer this one. At what age should you begin screening mammograms? 30, 40, 45, or 50? And I will give you just a couple of minutes here, and I'm anxious to see if we get results too. All right, final answers. I'm going to close this out. 3, 2, 1. Let's see if we got results this time. Oh, we did.
Oh,
and look
good.
at that. We have, look at our audience all being smart. Age 40. You guys did a really good job responding to this. We actually had some discussion. This is almost a trick question because there are a lot of guidelines out there. So Dr. Kulkarni, can you talk to us about what you recommend and what you think is best for women?
Yeah, I do think that was a trick question, Michelle, because there's so many guidelines out there, and they can be so confusing. Now, the United States Preventive Task Force has put out certain guidelines that kind of almost correspond with what I have up on the screen today. The American Cancer Society guidelines is what we follow, and as you can see, I've kind of spaced it out with the ages. The general recommendation is to start at 45. But women between 40 and 44 should have a choice to start their annual breast cancer screening with mammograms if that's what they want. And that is a discussion that women in that age group should be having with their physicians. Again, whether it be their PCP or whether it is their OB-GYN, or if they have actually sought the help of a breast surgeon or a breast specialist, they can talk with them. But definitely after 45, there are universal guidelines to start mammograms done every year. And this is where sometimes there is a difference of opinion between the ACS guidelines and the United States Preventive Task Force guidelines. But what I have out here is what I recommend to my patients. So after 45, definitely every year. After 55, You can switch mammograms to every 2 years if you so desire. But if you would be more comfortable continuing with yearly screening, that is definitely an option. And for the most part, my older patients kind of tend to ask me, so how long do I continue this? And the answer is different for every patient. If you're in really good health, and if something comes off of the screening mammogram that requires to be followed, and you're in such good health that you can definitely follow and get yourself treatment, then you should have your screening mammogram. If you happen to be in poor health and you don't think that you will be able to undergo any diagnostic or treatment options, if the screening mammogram were to show something, then that's when you kind of have that discussion with your physician and say, doc, this is where I draw the line. I don't think I would want any more treatment, so there's no point in doing any screening. And again, all of this should be a discussion with your physician. I don't think any of these guidelines need to be set in stone. They're not set in stone. And a discussion with your, physician provider should be what prompts when you have screening and how much screening you have. So for the most part, the screening involves starting with mammograms. And as with everything, all forms of screening have their advantages and disadvantages. I have women telling me, I hate having mammograms and then waiting for the results because it is so anxiety provoking. And that is true. Also, not all mammogram findings may be as they seem. There is what we call false positives, where there is something that looks like it's concerning, but it's not, or false negatives, where something doesn't look concerning, but it is. So I don't think, again, just like any sort of modality has its own pros and cons, so does mammography. But for sure, in today's day and age, you should be requesting for a digital mammogram that is three-dimensional or 3D mammogram. So the older version, the 2D mammograms, are fast going out of vogue. The 3D mammograms are far more accurate. These pictures actually depict Inspira facilities with their state-of-the-art 3D mammograms. And you can kind of see in this picture how well-defined those mammograms look and how much more they will pick up as compared to the older versions of the mammograms. Other modalities that are used in screening and in diagnosis are the ultrasound. And a lot of you may have happened to have an ultrasound, not for the breast, maybe for something else. It's a very, very user-friendly test where a probe is basically passed over your breast. There's some gel that's put on the probe, and the gel basically acts as a lubricant to allow for better images. And this offers, is often used with in comparison with the mammogram. So sometimes it's used for a finding on the mammogram to kind of delineate it further on the ultrasound. Sometimes it is used as a screening modality, and in more modern times, it has been used as a screening modality in women who have really dense breasts. The MRI is another tool that can be used for screening patients, especially those who are very high risk for developing breast cancer in their lifetime. The guidelines talk about if you have a more than 20% lifetime risk of developing breast cancer, there may be value to using the MRI as a screening modality in conjunction with the mammogram. MRIs are also used once you have a diagnosis of breast cancer. They're really sensitive in picking up whether there is any other disease in the same breast or in the opposite breast, and also for evaluation for any lymph node enlargement. Patients who may have had radiation to the chest as younger, as children or as young adults, and this has been used for lymphoma. This can be a very, very useful screening modality to make sure that any changes are caught really early in their lifetime.
I appreciate you walking us through those. I think the comment about the callback is really a helpful one, because sometimes there are findings on an initial mammo, and I think people tend to get very, very nervous with that. So it's good to hear that that is not necessarily uncommon, and We need to just remain calm and follow through with that process so we can get a final answer. So I'd like to have the audience answer one more question here before we transition over to our discussion about risk assessment and family history. So let's try this next poll. What percentage of breast cancer is genetic? Is it 5 to 10%, 20 to 25%, or 40 to 45%? What do you think? We'll give you a few moments here to answer. All right, final thoughts in. Let's see what you said. Okay, so we are mixed here. We've got a little bit across the board. So Dr. Kulkarni, I'll let you do the reveal.
Actually, I'm not surprised by this answer at all, Michelle. As you saw, a large percentage of patients seem to think that the majority of breast cancers are hereditary, whereas they're not. Only 5 to 10% of breast cancers are actually related to family history. Or transmitted through genetic mutations. This is a question that I face in the office a lot. I have breast cancer. Does that mean, my daughter or my niece or my sister is going to have breast cancer as well? And while having a first-degree relative does increase your risk for having breast cancer, the fact is that only in 5 to 10% of patients is this risk actually genetically transmitted. So a family history of breast cancer certainly increases your risk. Like I just said, if you have one first-degree relative, what I mean by that is your mother or your sister or your daughter was diagnosed. Or if you have had 2 first-degree relatives, then your risk is now almost 5 times the average. So where it was just double with 1 first-degree relative, it is now 5 times if you have 2 first-degree relatives. Another thing that, we tend to overlook is male breast cancer. So just because you're a man, it does not mean that you cannot have breast cancer. Now, the incidence is much, much lower, but unfortunately, because men tend to ignore any lump in their chest wall breast region, thinking it's, maybe just a trauma or something that's just benign, unfortunately, they get diagnosed much later. How this pertains to the woman in the family, if you are the daughter of someone who's had breast cancer, then as that actually increases your risk much higher than the average risk. There are several genetic mutations that basically predispose you to breast cancer. And you may have heard of the breast cancer genes commonly referred to as the BRCA1 and 2, or we call them the BRCA genes 1 and 2. These are, 2 of the most common genetic mutations. Although there are now more common, more and more we are diagnosing other genetic mutations that may be linked to breast cancer. So what we do at Inspira is very special and unique. We actually have a high-risk program that is known as Inspira Insight. And this is a very evidence-based online family history survey. The way we were administering it was when the woman comes in for screening mammograms, we were originally handing out an iPad on which they would enter their information, and it would call for family history, personal history, and it would actually flag their risk for whether they were at high risk for developing breast cancer. Now, we have adapted almost immediately to the COVID-19 pandemic because obviously you don't want to be touching an iPad in an area where other patients may have touched it too. So we have made it where you can actually scan a QR code or you can just access a link on our website, and it takes you directly to the questionnaire, and you can have a risk calculation through these means. And when it alerts you to being a high risk for developing breast cancer, you now have the opportunity to enroll into the high risk cancer program, where you would have a visit with a specialist nurse practitioner who completes a more in-depth history analysis and then decides, if you are eligible for genetic testing, whether you're eligible for, extra screening. Sometimes you're eligible for risk reduction techniques. And all of this can be customized, to your particular needs. So you end up with a very, very customized screening and surveillance plan that is then followed through by our providers.
And actually, you mentioned the link to that risk assessment. That is one of the tools that you will find in a resource list for our viewers at home. So feel free to check that out either now or at a later time. So these slides have been encouraging. I always like to know that there are some things we can do proactively to keep ourselves healthy or to ensure that we're catching disease earlier when it's more treatable. But sometimes we have early indications that something's wrong. So let's shift the conversation now to signs and symptoms and some things that we as women should really not ignore.
Definitely. So like I kind of pointed out in one of our previous slides, self-breast examination should not be slighted. There are a lot of research articles talking about how that is not important. But I think being self-aware is very, very important. So if you find a new lump or mass in your breast, it is definitely something that you should bring to the attention of your primary care provider. Now, in a lot of situations, I don't want you to be alarmed. A lot of times it's just a benign cyst or a benign tumor called fibroadenoma. But if it is a new lump, it warrants more investigation. It may require diagnostic tests or biopsies, as we will come to in a minute. Other signs and symptoms that you may see may be skin dimpling, something that wasn't there, a few months ago, and now you see your skin kind of getting pulled in at a particular point in your breast might be a warning sign. Breast or nipple pain, while it is, very common to get breast pain or nipple sensitivity, especially as you're going through your periods, any gnawing pain that is focused to a single point or, constant nipple pain should not be ignored. Nipple retraction is another thing that can sometimes be a warning sign. Again, some women have their nipple retracted just in one or the other breast since they are young. But if this nipple retraction is new, that's something that you should bring to the attention of your provider. Nipple or breast skin that is red or dry or flaking, or you feel like the skin is more thickened as compared to the rest of your skin, that's also a red flag. Sometimes you have breast cancer signs and symptoms that don't start as a lump at all. You just have the nipple and area changes, and they might be your first warning sign. Nipple discharge. Again, this is something that, we experience very commonly, and most nipple discharge is actually benign. But if you have bloody nipple discharge, so actual blood or blood-tinged nipple discharge, that is something that you probably want to bring to the attention of your primary care provider or your OBGYN, and it may need to be investigated. Also, if you have clear nipple discharge that's coming just from a single duct on a single side, that's another thing that probably warrants more investigation. But it's not uncommon to have yellowish nipple discharge or a milky discharge, or both breasts secreting clear discharge, especially if you have just finished or are starting breastfeeding. All of these are quite common. Even if you have fibrocystic breasts, that's another common presentation. But something that's changed over a period of time, or the, kind of the signs and symptoms that I've just talked about, definitely bring it to the attention of your provider.
Okay, so let's shift our focus to what happens next, whether something has shown up on my screening mammogram, or if I have a sign or symptom here and I've come to see my physician, what happens next? Can you walk us through the diagnosis and treatment process?
Sure. So I think it's really helpful to have at least an overview of what to expect. If you were to find something, what do you think is going to happen once you go to your provider? More than likely, the first thing that your provider is going to say after they, he or she examines you is going to be that they want additional imaging of the breast. So generally that involves a diagnostic mammogram. More often than not, that is accompanied by an ultrasound. So when you go in for your mammogram, the technique is a little bit different from the regular screening mammogram. In a screening mammogram, you will have the breast compressed between the plates of the mammogram machine. In diagnostic, they're doing that in different views. They're using magnification views, and then you may have an ultrasound right following that mammogram, looking at specific areas of concern in the breast. That may be followed by an image-guided biopsy. So if they see something that either unusual on the mammogram or on the ultrasound, if they see a well-defined lump or an area that looks abnormal, then the next thing they're going to request is a biopsy. So these biopsies are always image-guided. They're never done blind. The imaging that they may use might be a mammogram, in which case it's called a stereotactic biopsy, or it may be ultrasound-guided, or occasionally, neither the mammogram nor the ultrasound shows anything, but the MRI may have picked up an abnormality, and we can very well do an MRI-guided biopsy. And at Inspira, we have fabulous radiologists who are, specifically trained in all of these modalities of biopsy, and they ensure a very, very, pleasant experience, as pleasant as one can expect during a biopsy, but they ensure that you're comfortable throughout that entire process. Now, once you're diagnosed, if this requires to be removed surgically, then what we do is place a reflector within the breast. The particular reflector that we are using is called a Savvy Scout. It's a very tiny clip that has a micro reflector built into it, and it uses infrared rays. So there is no radiation. It's just basically infrared light that is used. The probe you see on the diagram there, that is used by the surgeon to basically localize exactly where the clip is. And so we are able to do a very accurate excision. Now, what I want to emphasize on this inverted triangle is should hopefully allay, some of the fears that you have. When I go in for a screening mammogram, does that mean necessarily that I'm going to be called back for more images? Especially if you've had that happen to you in the past, you're always worried when you're waiting for your screening mammogram test results. Am I going to get called back in? Will I need a biopsy? So maybe these numbers will help allay some of those fears. So of every 1,000 patients that undergo screening mammogram, only about 10%, so maybe about 100, will get called back for additional diagnostic tests. Of those 100, only about 10 will actually be called back for a breast biopsy. And of those 10 patients, only about 2 patients actually get diagnosed with breast cancer. So we started out with 1,000 patients getting screened to find the 2 patients who were actually suffering from breast cancer and were newly diagnosed. So hopefully that should, relieve the other 998 that they are not going to be necessarily diagnosed with breast cancer just because they got called back for additional imaging. So once we have a diagnosis, now the next step obviously is creating a treatment plan. And this is where our wonderful team at Inspira comes into play. We create a treatment plan that is customized for you. It is based on a multidisciplinary approach to breast cancer. It's not the one size fits all at all. So the most important thing that impacts your treatment plan, of course, is the staging. And a lot of you may be familiar with this term, but staging basically talks about how big is your cancer, has it spread to lymph nodes, has it spread to other parts of your body. And that's what decides whether you're a stage 1 or stage 2, which is early breast cancer, or if you're a stage 3, if it is, locally advanced breast cancer, or if it is stage 4, where unfortunately the cancer may have spread to other organs in the body. Obviously, when I say that we are creating a customized treatment plan, you are the key person involved in the decision-making at every point, every step along the way. Every situation is discussed with you in detail by all the providers that are involved in your treatment. And what comes out of that is a very, very personalized treatment plan that you have been a part of making as well. We do use very specialized tests. Sometimes genetic testing of the tumor can be used to decide if your tumor would, respond to chemotherapy or does it not require chemotherapy. We also involve genetic testing of the patient themselves. So if you are diagnosed with breast cancer, you would be offered genetic testing to see if there is a genetic mutation that led to the formation of cancer. Like I had discussed in a previous slide, 5 to 10% of the times, we do find that it is a breast cancer-related gene that may have caused the development of breast cancer. And so then we can accordingly plan your treatment around that information. Now, the treatment options, as I said, this is a multidisciplinary approach. There are several arms of treatment, the main being surgery, radiation, and medical oncology. So surgically, we'll go into that in a minute. There's different options. Radiation therapy involves special X-ray beams that are transmitted to the breast. And the medical oncology has several subspecialties within it as well. And we'll explore that in our coming slides. So when we talk about surgical options, these are designed with the specific size, the nature of your tumor, the size of your breast, and what are the reconstruction options that would be available to you. So broadly, these can be divided into breast conservation techniques, where basically we are trying to take the tumor out along with a small rim of breast tissue, and then we basically close the breast in such a way that it is cosmetically acceptable. The second option would be to do a mastectomy. This involves removing the entire breast, but this again has several nuances to it. We may do a skin-sparing mastectomy where we basically remove the nipple and areola, but we preserve most of the breast skin so that reconstruction can be done either implant-based or it may be flap-based where we use your own tissue, either from the abdomen or from the back, and that can be used to reconstruct the breast. In certain situations, we can even do nipple-sparing mastectomy, where we basically spare both the nipple and areola and most of this, and that is used to reconstruct the breast. So not everyone is eligible for all of these options. Again, they are customized, like I said before, based on the particular nature of your tumor, the size of the tumor, the size of your breast, and your general health. Coming to radiation, this beautiful machine depicted here is actually the machine that we have at our Mullica Hill Center. Radiation basically uses high energy rays to kill cancer cells. And these are highly targeted beams that deliver the radiation directly to the tumor site. A lot of patients ask me, but my heart is right behind that. Will I have any heart damage? I must say our radiation techniques have improved so greatly over the years that it is really, really possible to hone in on the area of the tumor and prevent damage to the surrounding tissues in a great way. Radiation is generally delivered after surgery. Most commonly after a lumpectomy or what we call a partial mastectomy, which is the breast conservation technique. But radiation may also be required in certain situations after a mastectomy. So just because the entire breast is removed does not necessarily mean that you won't need radiation afterwards. The treatment course may be over several weeks, although again, that is customized to the particular patient and their tumor size and their final pathology. And each individual treatment generally lasts, not even 10 minutes. So you're in and out of the radiation suit in 10 to 20 minutes at the most. Coming to the medical oncology options, unfortunately, the most dreaded of all the treatments for breast cancer does tend to be chemotherapy. People worry about the side effects, whether it be the nausea, the vomiting, or the hair loss. But the fact is that chemotherapy is one of the main pillars of treatment. It is treatment that circulates through your body. It is basically anti-cancer drugs that are given either intravenously. Sometimes they can be given by mouth. And as I had mentioned before, more and more we use genetic testing of the tumor itself to decide if you are a candidate for chemotherapy or you may not benefit from chemotherapy. The chemotherapy is administered in these very luxurious suites. The top one here demonstrates our suite in Mullica Hill. The bottom one is at our Wineland Cancer Center. And the experience is, again, tailored to your needs, whether you need to be, secluded in your own space or whether you would like to be in a more open environment, overlooking the grounds. That's something that you can choose. Other treatments that kind of are also systemic include immunotherapy, where we include or harness the body's own immune system to fight the cancer. And occasionally, and then of course, the majority of the times we end up using hormone therapy because a lot of these tumors tend to be hormone sensitive. These are basically medications that are used to block hormone receptors in the breast cancer cells. More often than not, they're used as an adjunct after the surgery and the radiation and the chemotherapy are over, and then you continue to take these in the form of tablets over a period of 5 to 7, sometimes even 10 years. Rarely these can be used if the patient is very, very sick and cannot undergo any of the therapies that we talked about. Then just hormone therapy may be used in order to keep the treatment, to keep the cancer under control. At Inspira, I cannot emphasize enough, high tech meets high touch. We are a nationally accredited program, and as I have said several times before, it is a very, very personalized approach to care. It's not a cookie cutter. It's not a one-size-fits-all. We have a multidisciplinary care team that is constantly talking with each other in order to personalize your treatment plan, whatever is best for you. We have physicians that are absolutely experts in their field, including subspecialists for each type of cancer. And we are using some of the latest and cutting-edge technology to provide an experience that is very, very comprehensive and more than anything else, delivered in one location. So whether you're at our cancer care center in Wineland or whether you're at Mullica Hill, in one building, we have the medical oncologist, the radiation oncologist, the surgeon, any other ancillary care systems that you may need. Everything is under one roof. So that's what minimizes your heartburn in trying to find offices and run from building to building. All appointments are made by our team. Our navigators will walk you through your experience. We hold your hand every step of the way. I want to emphasize on this slide, on the right top, you see the NAPBC accreditation. This is the National Accreditation Program for breast centers, and it is an absolutely important part, an integral part of being recognized as a provider for breast cancer care. And I'm proud to say that our center is NAPBC accredited. I'm going to let Michelle talk a little bit more about the support services that we offer at our centers.
So Dr. Kulkarni's done a fabulous job of outlining the clinical modalities, but we really take not only a personalized approach to your care, but a comprehensive approach to it as well. So you see the diagram here on the screen with the patient at the center. And that's really what we try to live out every day. And so it's not only your physician care team that's around you, but it's a variety of other support services that are there to help you all along the way. So whether it's our nurses in the infusion center or our social workers, our pastoral care department is always available. We have both nurse navigators as well as lay navigators who can serve as a primary point of contact for you, because despite the fact that our physicians tell their patients all the time to call, patients still feel like they're bothering. If that's you, just know our doctors really want you to call them if you have a problem. But we have navigators that can help to support you through that as well. We also have access to clinical trials. So that is a phenomenal opportunity that we can provide right here at Inspira. I think currently we have 3 or 4 research studies that are open related to breast cancer. So all of these are ways that we look to really support you as a whole person as you go through your care. One of our more recent developments that I'm very pleased to talk to you about is our partnership with Gilda's Club of South Jersey. Their mission is to deliver comprehensive patient support. And so we've partnered with them to be able to stand up virtual support groups. So we have one that meets every week, and we've got about 10 patients that have taken part in that. And it's through an online platform, but it's been incredible to those patients that are participating in it, in terms of giving them a forum to connect with other patients, other folks that are going through the same kinds of experiences they are. It's a really empowering experience for our patients. We're also just getting ready to launch, actually, I believe it's next week, we're going to be starting a family and friends support group. So not only do we recognize the journey that a patient takes, but those of us that support someone on their cancer journey also are going through a journey of our own. And I think that that's a really important factor that we want to make sure we're supporting, is the friends and family that surround our patients. So that's another care group that we are going to be offering very soon, just really speaking to the commitment to supporting the whole patient and their care team as you go through your cancer journey. So I hope that we have covered a lot of ground today, told you about the specifics of what you could expect from breast health and breast cancer treatment here at Inspira. Before we move over to questions, I do want to turn it back over, though, and let Dr. Kulkarni give us some final thoughts. I guess we're at the end of our journey. You brought us to that little dot that shows up on the map. So recap for us. Where have we been?
Glad to be your GPS for tonight. I do want to, re-emphasize what Michelle just said. On this road, on this journey, please do not ever feel that you are alone. We are here to hold your hand and walk you through every milestone and celebrate at the end with you. But on that road, there are some actions that you can take. Take charge of your life, of your health. And one of the things that, you can do, as we talked about, do a monthly self-breast exam. It's a very simple thing. It's just getting to know yourself, getting to understand your own body. Get your annual mammogram. If you've crossed 40, definitely talk to your provider. Get your mammogram every year. It saves lives. Talk to your provider. If you feel like you feel something, you're not sure, don't sit in that anxiety. Just talk to your provider. It's better to be proactive and get things checked out and find out that it's nothing than, wait until something's now advanced. I can't tell you how much it breaks our heart when, we have a patient that comes in and we only wish they had taken charge of their health a little bit sooner and we could have helped so much more. Understand your family history, ask questions. I do understand that sometimes it's a delicate issue. Sometimes your family members are estranged or you may be, adopted. Do your best to find your own family history so that it can empower you to take decisions for the future. So just a few things that, you can do as you are walking along this road with us.
Well, with that, Dr. Kulkarni, I want to thank you for being a fantastic guide this evening. I hope for our audience members that you have found this informative And I'd like to transition us over to the Q&A session. We do have quite a few questions that have come in. So I'm going to do my best to get us through these with the time that we have allotted. So the first question is, do you need a script to have a mammogram?
Yes, you do need a script, and generally that can be provided by your primary care physician. It can be provided by your OBGYN when you go in for your annual checkup.
Here's one that goes back to our risk factors and talking about what we can control. You had mentioned BMI. So the question is, what do you consider a healthy BMI?
That's a great question. I don't think I have like the exact number off the top of my head. That's something that you will find in a range. It's generally, I would say, between about, if I'm not mistaken, between 20 and 25, but I will double check on that fact. It's something that, again, your PCP might be actually able to help you with, because BMI is just a number. Sometimes you have to take into perspective that your BMI may be slightly higher than what your average or ideal BMI is noted, but you may be very healthy overall. So don't just go by that number. Definitely when you're in with your primary care provider, your overall health is what counts.
Here's another one. I've had breast cysts before. Does that put me at a higher risk for breast cancer?
No. So having a breast cyst is actually very common. It's what we call fibrocystic breasts. It's one of the things that I mentioned before, that when you're palpating the breast, when you're doing your self-breast exam, you may find a lump, and it may actually just turn out to be a simple cyst. A cyst is nothing but a fluid-filled, little bubble inside your breast. And it is usually a benign finding. Having a cyst does not predispose you to having breast cancer. Having said that, sometimes there may be changes in the vicinity of a cyst that may be picked up on an ultrasound, and those might be concerning, but a cyst by itself does not predispose you.
Can you address the amount of radiation in an MRI and or mammograms, and does it affect breast health over many years?
That's a great question. I'm glad someone asked that. So first of all, an MRI does not use radiation per se. It's actually using the ionization of water in your cells, and I won't go into the technical details of it, but it is not the same kind of radiation as is used for mammograms. The radiation exposure in a mammogram is very, very minimal. Believe me, you're getting exposed to more radiation on a daily basis through the sun, or if you take a flight, which of course with the pandemic now, who is, right? But there's probably more radiation exposure there than in your mammogram. So that does not affect your overall health. It does not predispose you to developing cancers over your lifetime just because that amount is so small.
We talked about some of the factors for breast cancer, such as age of menstruation, childbirth, menopause. They can be risks. Is the risk related to those things, to you being older or to you being younger? So if you talk about like age of menstruation, are you at higher risk if you start earlier or if you start later? And then the same for childbirth and menopause.
Right. So it's basically the amount of exposure to estrogen, the period of time that you have been exposed to it. So if you have a really early start of menstruation, so you were very young when you started, and a very late age of menopause, that's several years that you're exposed to the fluctuations and to the hormone. As you know, after menopause, the estrogen level drops dramatically, so your exposure really drops after that. So the period that you have been exposed, so younger age at start of menstruation, older age at menopause is what is a higher risk factor. Age at pregnancy, surprisingly, childbirth actually, the younger you are, it might actually protect you, but obviously that's within reason. And then if you breastfeed, that is actually considered protective against breast cancer in the future.
Very helpful. Here's another one. I used to get my mammogram at a center that promoted that the mammo was read by 2 radiologists. Is that still something that's needed for now that we have 3D mammo technology?
I wish I could defer this question to our radiology colleagues, but I will tell you that the 3D technology that is used today is actually very smart technology. So in addition to the image being crisper, for the radiologists when they're reading this, and I know this because I have actually sat in the room with them when they do this, they have computer-aided detection, or CAD as we call it. So the computer is analyzing the mammographic picture as they're going through the films, and it actually brings up areas of concern that then kind of the the radiologist is able to hone down on and see if that's truly an area of concern or not. And what they do is, generally, if you've had regular mammograms, they will refer back to your older images and compare them and see if that point that was brought up by the computer, is that just a blip or whether it's an actual change from a previous mammogram. So that's how they kind of double check. And I'm pretty sure that just as we all do as physicians, if there's anything that needs fact checking, there is a lot of internal dialogue between physicians, and they call their colleagues in to kind of comment on something that may be controversial.
Here's a question. From what age can you get breast cancer? We know you should start your mammos at 40, but is there an age when you're starting to see folks getting cancer, breast cancer?
Unfortunately, some of the breast cancers can start really, really early. I would say the youngest patient that I have had in my practice has been in her 20s. So it's really unfortunate, but that situation is very, very rare to have a breast cancer so young. And more often than not, such a young breast cancer is linked to either a very strong family history and or an actual genetic mutation that has caused the breast cancer so young. More often than not, it's, as you approach your mid-40s is when the incidence starts rising.
Okay. Kind of a general question. I mean, we talked about the survivor stat, which I think is impressive, but this question is, why do so many women die of breast cancer with all of our advances?
I wish I didn't have to answer that question. I'm hoping to someday get to a point where we can say no woman will ever die of breast cancer. But I must say, if I compare statistics from, even 10 years ago to now, we have more and more women actually living in more advanced stages of the cancer. But to answer your question, unfortunately, it is related to the fact that a lot of women wait to get their cancers diagnosed and taken care of. There is a lot of fear of, undergoing the treatment. There is a lot of fear of just getting diagnosed. I definitely have women who come in with masses that have, pretty much taken over the breast. They've ulcerated through the breast, and there's foul-smelling discharge sometimes, and they are still afraid to come to the doctor to seek help. So a lot of the fact that, women die from breast cancer is related to the fact that they come in later stages of their disease, and it becomes a little bit more difficult to help them at that stage then. Also, we do see some more aggressive variants of breast cancer. So, the more common variety is the hormone receptor positive cancer, but some of the hormone receptor negative, or you may have heard of triple negative breast cancers, these tend to be inherently quite aggressive. So while we're making breakthroughs, even in these triple negative cancers, they may be some of the contributors to early breast cancer deaths.
Okay. And we are running right up on our time here. So I think with that, and that's actually a kind of a good note to end on. I think it really speaks back to the importance of screening and being proactive and knowing your own body and paying attention to that, because the earlier we can detect breast cancer, the better off the prognosis usually is. So, Dr. Kulkarni, I want to thank you again for being our guide this evening. To our listeners at home, I hope you found this informative. You will get a recording of this, and you will still have access to those survey or to those resources that are in your windows there. So we hope that you take advantage of those, and know that Inspira is here for you on your breast health journey. We are your partner. So we wish you a good night. Stay safe, stay healthy, and thank you very much.
Have a great evening.